moderate or severe endometriosis. So in this case, there is no role of surgery prior to the fertility management, particularly when you are planning surgery for improving fertility. Okay, if you are planning surgery because of pain, go ahead. If you are planning surgery because of any other reason, go ahead. But if you are planning surgery to improve the fertility, no. It's a big no, no. Okay, so very warm welcome to this session. And I'm so happy to see some of my students, which are being with me for quite a bit time. And of course, very warm welcome to the new students as well. Okay, so we are doing the self-fertility module. The first module we have started in this batch. Live session is yet to happen. So if anybody is planning to join, you are very much welcome. You haven't missed anything much. So this is a recent TOG article in January review. And you all know that TOG articles has become of late very, very important for exams. And now it is not like that. You don't have to read TOG article, which was published 6 months back, which used to be a thinking, I think, around 1 year before. But now it is not that. You have to read all the TOG articles, and questions do come directly from the TOG articles. And endometriosis itself is a very, very favorite topic of RCOG. RCOG always loves endometriosis. So now this is a recent TOG. So that is why I have decided to take it up in the live session so that we can talk about all the intricacies. And second thing, what is important is there, whenever we have two sources for any particular topic, then we have to balance. We have to make a clear answer. Otherwise, statements are so contradictory between the two topics that when you see a question in the exam, you become confused whether to follow the TOG or to follow the guideline. So similarly, endometriosis is also one such topic. We had a NICE guideline for endometriosis, which NICE guidelines are always the backup for all your, they're the backbone of your EMQ questions, right? So NICE guidelines are always, always very important. And then there is a part of endometriosis management also from the NICE infertility guideline. So now this is one addition into that. So how we are going to balance that and how we are going to answer questions in exam, that is also we are going to talk today. And please, whoever is joined, try to remain till the end, because we will also practice question based on the knowledge we have gained today. Okay, so we will be practicing the questions new as well as the old one, from the prior books, and see what is the difference this TOG article makes in our answers, right? So that's about this particular session. So anything, any of you wants to say, or I start? Anything you want to ask, you want to say, you can just go ahead, or else I'll start. Right? Okay. So let's start. And if anyhow you want to ask anything, you can interrupt me in between. I don't mind it at all. You can just let me know whatever you want me to repeat. I'll be happy to do that. Okay. So what are the learning objectives for this particular session? We are going to talk about epidemiology. Epidemiological percentages, RCOG loves it. Okay. So many percentage of women get this disease? What is the percentage in self-fertility women? So these are important percentages, and we are going to talk about it. Mechanism of self-fertility in endometriosis. What are the investigations need to be done? What are the management options? And then if we go for the ART, we are giving hormones, right? So what do the effect of these hormones on endometriosis? That also we need to see. And finally, when we take both together, TOG and NICE, both informations, what difference it makes in our exam scenarios. And finally, we'll practice some questions. So I think sounds good to everyone. So let's start. Epidemiological and prevalence. So first, In general population, what is the prevalence? 10% in women of reproductive age, right? So 10% of women of reproductive age have endometriosis. Now, if we talk about the population with the subfertility, then it rises to 25 to 50%. So 25 to 50%. So quarter to half. Okay, you can have these words. Instead of 25, you can have a quarter, or instead of 50%, you can have half, or something in between, like 1/3. So because 1/4 to half, that is the range. Okay, if you have options in exam like 50%, 40%, 30%, 20%, then you have to go with the highest one, right? So 25 to 50% in women with subfertility have endometriosis. Very, very important percentage because it's very high percentage. Now, what about deep endometriosis, right? When do we call it as deep endometriosis? When it involves like the rectum, urethra, urinary bladder, or into the pouch of Douglas, or there is the various other organs are also involved. So deep endometriosis is there. But they are around 20% of the women with endometriosis have a deep component to their disease. Okay, so 20% of the women with endometriosis will have a deep component. Now, the next information I'm going to give you may surprise you. Okay, endometrioma. When endometrioma is present, it is a marker of more severe disease, right? Then the disease does not remain largely milder. Most of the cases, right? Or it's not a strict criteria, but it can be considered a marker of more severe disease. 50% of the women with deep endometriosis will have an associated endometrioma, right? Again, an important percentage here. 50% of women with deep endometriosis may have associated endometrioma. Why I am focusing too much on this point and saying that this might surprise you? Because 50% is a big number. Secondly, endometrioma is a very frequent finding in the patients with endometriosis. And most of the exam questions also revolve around the management of endometrioma. You like questions come in exam like you did a laparoscopy, you find a 3 centimeter endometrioma, you had a 2.5 centimeter endometrioma, you had a large endometrioma. So what you are going to do? So this is a very, very favorite question of RCOG. Size of endometrioma and how you are going to go ahead. In the next further slides, we are going to talk about these scenarios. Now, what is the mechanism for endometriosis related infertility? So, this is the cycle. You can see it is not just a single thing, not just the tubal distortion or the tubal blockade, which is considered largely to be the main thing, but that is not the one thing, okay? So anatomical distortion is just one part of all the things which can occur in your endometriosis. Anatomical distortion, which might include either the tubal blockade, there can be hydrosalpinx, there can be adhesions in the pelvis. Adhesions can be so much that it can cover the whole ovary, the egg is not released, and so, or it cannot be picked up by the fimbrial end. So there are multiple anatomical distortions which can be responsible. Now let's look at the other factors. Dyspareunia. A simple dyspareunia can precipitate subfertility, right? It is a very important factor, and particularly patients with endometrioma, which have like pelvic congestion or maybe endometrioma in the POD that leads to more endodyspareunia, and that is also an aggravating factor for the subfertility. Then presence of endometrioma leading to problem with the ovarian reserve. Oocytes, the problem with the oocytes. Oocytes are not of very good quality when endometrioma is there. Because endometriosis is basically a chronic inflammatory disease. And since it's a chronic inflammatory disease, large number of cytokines and the chemotactic factors are being released, which leads to change in the milieu and which leads to basically the poor quality of the oocyte formation. Of course, if there is any surgery, then again the adhesions will cause the problem. Effect on egg, I already told you, poor quality oocytes is there. See, aneuploidies are not increased. Chromosomal abnormalities are not increased, but the oocytes are not of very good quality. Endometrial receptivity, again an issue, because if at all the fertilization occurs, then there is problem with the implantation, right? So endometrial receptivity, again, this is because of chronic inflammation. Acute inflammation is a routine part of the menstrual cycle. And because there is like shedding of the endometrium and then proliferation, so bit amount of the inflammatory reaction is going on in the normal menstrual cycle also, but that occurs in phases. Like that is for a small phase, then it comes to normal. While in cases of this particular endometriosis, it is a chronic inflammation. So chronic inflammation leads to problems. So there is a problem with the endometrial receptivity as well. So now when we look at so many factors, then ultimately when we have to define what are the management options, then we have to take all these into consideration. Now there are few more important incidences, and just to make it easy, I have clubbed them together and remember as 30%, right? So 30, a number for the endometriosis talk. So women with endometriosis have tubal pathology. So 30% of women with endometriosis have tubal pathology, right? So 20% of the women have the deep endometriosis. 30% of the women have tubal pathologies. 30% of the women who have endometriomas, right? Women who have endometriomas, out of these, 30% will have bilateral cysts, right? Now, 30% of the endometriomas recur in 2 to 5 years after surgical management, and 81% occur in the same ovary. So 30% of the endometriomas, they recur in next 2 to 5 years when you treat them surgically. This is a very important fact because you do surgery for the, so that you get proper ovary functioning for the fertility. But what is happening here? In next 2 to 5 years, 30% are recurring and 81% occur in the same ovary. So huge number is recurring again. So you have a very limited time. That is what this particular incidence means. Now, cystectomy for endometriomas on ovarian reserve showed a 30% reduction in AMH. Again, very important figure, because when you do cystectomy, like what is the concept? If a endometrioma is greater than 3 centimeter, we have to remove it. And then you go for the fertility. So when you have removed it, when you have done cystectomy, there is a 30% reduction in AMH, right? So ovarian reserve is decreasing. Two main things we use for ovarian reserve, AMH and AFC. So it is going to be decreased. So 30% reduction in AMH you can see with cystectomy. Therefore, these four incidences are very, very important, and I've clubbed together so that you can remember it as 30%. Some are 1/3 or 30%, means 30 to 33%. What about the investigations? Now with this patient, when a patient like this comes for, we are particularly talking of endometriosis in relation to subfertility only. I'm not talking of endometriosis in general, right? So holistic diagnostic workup for subfertility is needed. Ovulation test and semen analysis are always the basic tests. So they have to be done in these patients as well. Baseline ultrasound is always important, and tests for tubal factors and tests for ovarian reserves are to be done as the basic tests only, because usually we don't do these tests in all the patients. Tubal factors, AMH and AFC, we don't do for all the patients of subfertility as per NICE guideline, but these patients require these testing. Now, what is the first line imaging technique? What is the first line imaging technique for these patients to determine the extent of endometriosis or to find out where are the lesions of endometriosis? What is the first line imaging? Anybody would like to answer?
Ultrasound.
Ultrasound. Yes.
Ultrasound.
Everybody agrees to that. Anybody would like to go with MRI? Ultrasound. Right. So everybody wants to go with ultrasound? Yes. Very clear. The first line in imaging is the ultrasound. Right. So baseline ultrasound we have already done and we are okay with that. Now for the deep endometriosis, we have to see what all are involved. So advanced ultrasound and MRI. Now what is advanced ultrasound? What do I mean with the advanced ultrasound? Now as per NICE also, your NICE guideline also says that whenever there is a possibility of deep endometriosis, you have to send the patient to specialist endometriosis centers, right? So there are specialist endometriosis clinic. In NHS, there are 3 levels at which the endometriosis patients are dealt with. One is the primary level, GP level, right? Patient with dysmenorrhea, dyspareunia, or any such complaint, she goes to the GP. She tells her, and GP thinks that this could be endometriosis because it is like a cyclical pain type of picture is there. So what GP will do? GP will give her certain analgesics. GP has also rights to give her COCs and try COCs for 3 months, right? It does not work. He refers the patient to gynecologist, right? Now, gynecologist will diagnose whether this is a case of endometriosis or not. So TVS is the first line. And as per NICE, the laparoscopy is the gold standard. So as per NICE, if on laparoscopy there is no lesions, then you can rule out endometriosis and you can think of any other condition leading to pain, right? This is what NICE says, okay? So that is, and then the patients in which deep endometriosis is suspected, they will go to the 3rd level. That is the specialist endometriosis centers, right? So now this advanced ultrasound is for deep endometriosis. So therefore it is written as advanced because this particular type of scans where they will look for these all things will be done in specialist endometriosis clinics by the specialists who are trained to work for endometriosis patients, right? So all deep endometriosis patients will go to this 3rd level. That is the specialist endometriosis clinic. So therefore, the word used here is advanced ultrasound. And it could be MRI. But for exam point of view, you will always choose ultrasound as the first line and don't directly jump onto MRI. TOG says that they both are first line and you can choose them according to the clinical level of a person who is performing the imaging. Whichever way he is comfortable, he can choose either of these. But for part 2 exam, we have to fix one answer for our questions. So we will fix as ultrasound, right? So ultrasound is the one which is the first line investigation. Gold standard as per TOG is nothing. As per TOG, they say that TOG is largely based on X-ray. So they say that laparoscopy is not a gold standard. And why would we go and do laparoscopy in all the patients? We should not do laparoscopy in all the patients. And secondly, there is high complication rate with the laparoscopy. So TOG does not take it as a gold standard, but TOG even does not mention anything for the gold standard. So for exam point of view, if your question still comes for gold standard and you have to choose among various options, then laparoscopy is still the one answer which NICE says, because TOG does not go with any of the gold standard, right? So what is the role of laparoscopy as per TOG? The indications include patients with negative imaging. See, they are writing the same thing, that whenever you don't find anything on the imaging, you can do laparoscopy. Writing the same thing, but they have mentioned one line that it is not gold standard. because if at all you still not see the lesions on the laparoscope, you will not rule out endometriosis if you suspect it. That is why they are not taking it as gold standard. So patients with negative imaging, empirical treatment was unsuccessful or inappropriate. So same things, what NICE said, indications are same. When you can't find anything on the imaging and you still suspect, strongly suspect this is endometriosis, go ahead with the laparoscopy. And NICE also says that when you go for laparoscopy, you take a consent that, like if you see a lesion, you can ablate it or you can take a biopsy. Whatever possibilities can be there, you can take the consent. When you are going for the diagnostic laparoscopy, you can take consent for operative as well. But again, remember, deep endometriosis is not a domain of gynecologist, right? So you as a basic gynecologist will never choose to touch deep endometriosis. If you do a diagnostic laparoscopy and you see a picture of deep endometriosis inside, you will come out without doing any of the operative procedure and refer the patient to specialist endometriosis clinic. Understanding these pathways is very important because the questions come like that. Patient is in the GP level, patient is in the gynecologist clinic. So you have to see at what level, what things can be done. So role of laparoscopy is there when there is no imaging, you can't see any lesion on the imaging, negative imaging, or patient's treatment is unsuccessful or inappropriate. Now, why they are saying that we should not do laparoscopy for all patients? Because they say that because of the adhesions and all the milieu, the complications of the laparoscopy are more. So they are as high as 1 in 200 cases. Normally in serious complications, what is the normal incidence for serious complications in laparoscopy? Anybody? Why we are saying that this is high? What is the normal figure we quote? Yes? Consent advice?
2 in 1,000, ma'am. 1 in 500.
Very good. So 2 in 1,000, that is 1 in 500, right? So
Yes,
here they are quoting that in these patients, it comes to 1 in 200, right? And that 1 in 200, and that even rises to 7%. So 7% means 7 in 100, right? So it rises to 7 in 100 or 7% when we go for the complex surgeries. So therefore, they are saying that we should not do laparoscopy in all of these patients, right? So we should only do when we really want to intervene, when you really want to go for some surgery. We should not do laparoscopy only for the diagnosis point of view. Right? Got all the points still here? Any confusion anywhere? All well?
yes, ma'am.
Okay. So the next thing is now coming to staging and scoring endometriosis, right? Now, as we are talking here about in context to subfertility, so our prime concern is that we should know which patients can conceive naturally and which patients require ART. And if at all we are going for the surgery, then is the surgery going to improve the outcome for the natural conception or not? So that is the main point why we want to stage endometriosis, right? So initially, this is American Society Reproductive Medicine. This was updated, scoring was there. So it was designed to classify the extent of disease and its relationship with the pregnancy rate, but it does not correlate well with pain or subfertility, right? So now this is just taken as one part of the further scoring system, but it in itself, it does not correlate with pain or subfertility. There are multiple other factors which come into account. So this is not sufficient. Then came out the NZN. So this also has a limitation, like it is good for the prediction of what laparoscopic operating time. I mean, what is the complexity of the surgery? and how much time it is going to take. So it can predict that effectively, but it cannot predict the stage according to symptoms or any prediction for the infertility or any prognosis for the infertility patients. So then came out this, right? So in endometriosis fertility index. So this is a 10-point scoring system. Now it has taken account all the various things which are involved in the infertility, starting from the age, ovarian reserve. So they are taking into account all of these things. So 10-point scoring system grouped into 5 categories of risk performs well at predicting non-IVF pregnancies, rates post-surgery, and also it predicts good, although initially it was created to predict the pregnancy rates in the patients who are going for normal conception after surgery, but later on it was also found to be effective in predicting the ART outcomes as well. So what is EFI scoring? This is endometriosis subfertility index. So this is the form. Here you have to calculate the least function, right? So least function is calculated. So how it is calculated? This is left side and this is right side. 3 things are there: fallopian tube, fimbria, and ovary. Whatever condition is there, accordingly they are scored. So 4 is the score for normal, 3 is mild dysfunction, 2 is moderate dysfunction, 1 is severe dysfunction, and 0 is absent or non-functional. So the lower the score, more the severity, right? So lower the score, more is the severity. Higher the score, better it is. Then this index had historical factors and surgical factors. Now historical factors include age. So person is scored according to age, 210, years of infertility, prior pregnancy. So these are these factors. And then here it is the surgical factors like LF score, that is the least function score, AFS endometriosis score, and AFS total score. Now you take account into all these factors and calculate the total EFI score. The higher the EFI score, better it is. Now you see here 0 to 3, 4, 5, 6, 7, 8, 9, 10. So as the score is higher, the chances of conception are higher, right? So chances are increasing as the score is increasing. So that is the purpose of EFI score, and it matches with the pregnancy rate. So better the score, the good is the pregnancy rate. Now, what is the management? How the patients of endometriosis related subfertility are managed? Of course, they need a multidisciplinary team, including a gynecologist with expertise in treatment of endometriosis, colorectal surgeon, urologist, specialist nurses, and input from the fertility specialist. So these are the patients who are basically, they require treatment for the fertility, right? They are subfertile and they have endometriosis. I'm not talking of only endometriosis. Okay, again and again, I am telling you this because in exam you can have questions about both scenarios. One scenario is where the patient is having endometriosis and she comes with pain and all those problems. Then they have to be managed as per NICE. When patient of endometriosis comes for subfertility, she has to be managed at the tertiary level, that is the 3rd level, and multidisciplinary team is going to come into action because fertility specialist is very important part of it. So patient has to be referred to fertility specialist. Now these are the various treatment modalities we have. What are the recommendations and what is their evidence? Medical management. Medical management, which I told you as per NICE, GP gives analgesics, they can give COCs, but all of these lead to ovarian suppression. So ovarian suppression is the mainstay of treatment for the medical part of endometriosis. So because it leads to ovarian suppression, so anyway, it does not have any role in the management of patients who are managed for subfertility. So ovarian suppression should not be prescribed to improve subfertility related endometriosis. Evidence, no benefit. right? So medical management is out of rule, right? Now comes the pre-surgical medical treatment. Pre-surgical medical treatment means you are combining surgery with medicines. So you give some hormonal treatment initially and then you do a surgery, right? For like you see endometrioma, so you give COCs for 3 months and then you go for the cystectomy. Does this make sense? So evidence shows no. Did not seem to improve the pregnancy rate. So no benefit, so not recommended, right? Now coming to post-surgical hormonal treatment. Now what is the role of post-surgical hormonal treatment? It shows benefit. It shows benefit, but clearly does not show any effect on the pregnancy rate. It has benefit because it prolongs recurrence, right? It has like good effect on the pain. Patient will not have pain after surgery for the long time. Recurrence will be delayed. You will have more time for the patient to wait for the natural conception. But then again, the same thing, it does not show, this does not equate the rise in pregnancy, right? So this is more of like not giving benefit for fertility, but it is like no harm. It is not causing any harm to the fertility, but even it is not causing any benefit. So evidence for no harm. So it can be used, but with the intention that you want proper pain management, or you want delayed recurrence, for which you are giving this to the patient who is ready to wait some time for trying to conceive, right? So not given to improve the pregnancy rate, but can be given to delay the recurrence, to give a better comfort period to the patient. Okay, so it can be given after discussion with the patient. If she is not ready to conceive right now, you can give her. So this is evidence for no harm. Now, what about the surgical treatments? Now, there are two types of scenarios. One is mild, minimal or mild, and another is moderate and severe endometriosis, right? So what happens in minimal or mild endometriosis? So these patients, your NICE guideline says that mild endometriosis patient, they can try for 2 years, and if it does not work, go for the IVF, right? We have 3 scenarios for the IVF now. We after waiting for 2 years. One is unexplained infertility, one is mild male factor infertility, and third is mild endometriosis, right? Am I right? Agree? Yes or no?
Yes, ma'am.
Yes. So these are the 3 things, right? So what is the difference here? Now, the difference here is they want to know whether if we do surgery in the mild patients, is it going to improve the outcome or not? So this says yes. Laparoscopy could be offered as a treatment for endometriosis related subfertility for early stage endometriosis. So if there are small endometriomas or small foci which you can remove, so it is a mild endometriosis, then if you are doing the surgery, then it improves the rate of ongoing pregnancy. But again, this is for the natural conception. I'm not talking in terms of ART. Why I am saying this? Because it does not translate same in the ART. Because when you are operating on the ovary, you are decreasing the ovarian reserve. So it does not translate into the ART. For natural conception, it is good that for mild to moderate, minimal or mild endometriosis, laparoscopic surgery prior to giving any trial for the natural conception has shown good results. Now coming to moderate or severe endometriosis. So in this case, there is no role of surgery prior to the fertility management, particularly when you are planning surgery for improving fertility. Okay, if you are planning surgery because of pain, go ahead. If you are planning surgery because of any other reason, go ahead. But if you are planning surgery to improve the fertility, no. It's a big no, right? So no surgery in cases of deep endometriosis, moderate or severe endometriosis, because it does not improve the fertility. It has not shown any benefit. So what things have shown benefit? Only in mild cases, if you think that you can operate, you want to operate on it, then it can give you a benefit in the pregnancy rate. Otherwise, no medical treatment or no surgery is going to be beneficial in these patients. Now, what about the endometriomas? Specifically, I told you endometrioma scenarios are very favorite of RCOG. So let's talk about a bit more detail for the endometrioma management. Endometriomas are associated with reduced ovarian reserve as measured by the AMH levels and AFC compared with age-matched controls. The impact is associated with the size of endometrioma. The problem starts when the size is more than 3 or above 3, right? Below 3 does not make a much difference, but 3 and above 3, it starts making a difference. And large endometriomas again make a lot of difference. So excision of larger endometriomas greater than 5 to 7 centimeter and bilateral endometriomas has been shown to have the greatest impact on ovarian reserve. So larger endometriomas greater than 5 to 7 centimeter, particularly if they are bilateral, that has the greatest impact. The risk of premature ovarian insufficiency after bilateral cystectomies for endometrioma is 2.4%. Marked, so important, right? So even when you are doing bilateral cystectomy, very important point for counseling. For part 2 students, it is important, and for part 3 students, it is even more important, because this is a very important point to counsel. You are doing the surgery for fertility and patient goes into premature ovarian insufficiency. Your whole thing is wasted, right? So premature ovarian insufficiency can occur in 2.4% of these patients, right? Now, when comparing post-operative pregnancy rate between cystectomy, ablation, or simple drainage, then cystectomy and ablation has a pregnancy rate of approximately 30%, whereas simple drainage was significantly lower. So, this is never preferred. Drainage is never preferred. It is cystectomy which is the preferred one, and this is what NICE says as well. Whenever you have to plan the surgery, cystectomy is the best thing to do. So you have to remove the complete cyst. There is another new thing which they have included here, different type of surgery, which is 3-stage excision. So what does this mean? They are doing it is in 3 stages because this is for the larger endometriomas, because larger endometriomas, you remove a lot of ovarian tissue. So ovarian reserve can go further down. So therefore, this technique has been developed. Laparoscopic cyst drainage is done. A cyst is drained. Then you give GnRH agonist down regulation. And then you repeat the laparoscopy to excise the cyst capsule, right? So it's a 3-step procedure, 3-stage. First, laparoscopic cyst drainage. Then for a few days, you give GnRH agonist down regulation. And then you excise the cyst wall. So this has shown that the improvement in the AFC is more post-operatively as compared to only cystectomy. But they are indicated, this type of this practice is indicated in only few conditions. So management of larger cyst, when there are big cysts, particularly more than 5 centimeter. This 5 centimeter should be here. By mistake, it is here, right? So management of larger cyst, that is more than 5 centimeter. Or this is the second point, in women with bilateral endometriomas. So bilateral, larger cyst, or in women in which previous cystectomies has been done. Already you have done a cystectomy and now again there is a huge cyst. You want to remove it. So again and again if you operate, ovary is going to get damaged. So therefore in those cases, it is this type of technique is tried, right? So 3-stage excision. process. Now, what are the rules here? More than 3 centimeter, we have to think about surgery, not less than that, right? Now, if it is a mild or minimal endometriosis and we are planning natural conception, then surgery is a good option. But if we are going for ART, then no need of removing the endometrioma, because endometrioma removal does not help in improving the pregnancy rates with ART. So patient going for ART, you are not going to do the cystectomy. Directly you can go for the ART. Only in the conditions where the ovary is like frozen, it is covered by the adhesions and you don't have a proper place also to do the ovum pickup and all those things, there you may like to go with the surgery to release the adhesions and get a proper planes. That's it. Otherwise, for this for ART, like if you are planning ART procedures, then no need to do the cystectomy prior to that. Of course, if it is huge endometrioma, bilateral endometriomas, then you can follow the new techniques. Now, what about assisted conception? Minimal or mild endometriosis appears to have no impact on clinical pregnancy rate or live birth rate. By contrast, the presence of moderate or severe endometriosis significantly lowers the number of eggs collected and reduces the live birth rate by nearly 1/4. So number of eggs collected is less. So what happens with ART? Also, there are chances of cycle failures because there is difficulty in creating large number of eggs, and sometimes the patient may even need twice the dosages of gonadotropins which you use for the normal patients. So twice the dosages can be required and still you may not get good eggs, and so cycles need to be cancelled. So there is increased cycle cancellation if you go for the ART procedures. But still, IVF should be considered first line treatment for all these moderate and severe patients. Now, what is the role of IUI? As per NICE fertility, there is no role of IUI, right? As per NICE endometriosis, there is no role of IUI. Now, the TOG says that because IVF is a costly procedure, right? And as you know, in UK, everything is funded by NHS. So NHS keeps on weighing with the cost, right? Secondly, there is a large queue. IVF is an invasive procedure. So they say that there can be a role of IUI, particularly if the patient has mild or minimal endometriosis and all other factors are normal. Particularly, you see everything here. Ovarian stimulation. This ovarian reserve is good. Maternal age is fine, that is less than 40 years. Tubes are patent. Semen quality is good, right? So patient is ovulating, otherwise also. Maternal age is good, less than 40, tubes are good, semen quality is good. Then in those cases, you can offer IUI. Now, studies have shown that if you offer only IUI, then even if the tubes are patent, even if the patient is ovulating, still the conception rate is much low as compared to the normal people. Because again, as I told you, there are multiple factors which are coming into play. Oocytes are not of good quality. Tubes are patent, but functionally not so good. Endometrium is not good. So overall, there are multiple factors. So what they say that when they have seen that with IUI, if you do ovarian stimulation, you do super ovulation, as same as you do for your IVF procedures, but you do IUI, right? So you have got more number of oocytes, but you are not trying IUI because you think that the tubes are patent, they will work, and semen quality is also good. So this should overall work. And of course, it is only for the mild to minimal endometriosis. So by the time they are waiting for the IVF, meanwhile, you can give them a few trials of IUI if everything else seems okay. So this is new thing introduced by the TOG, right? So very, very likely to be asked in exam. We'll just now see one question where this type of answer can fit, right? So see that if they're specifically mentioned that patient is ovulating, patient has everything normal, they give you age less than 40 years, they have given you only one stigma, like one endometrioma or something, which shows that one thing is there, so she can try to conceive. Or where she is going for donor sperm, same sex relationship. Okay, so they are going for the donor sperm. So donor sperm, if they take, that is for the IUI only, right? So in this case, by the time they are trying, they can try for the with the IUI, right? So this is a new thing introduced in the talk and very, very important. Now, this is the summary, what we have read till now, because this was a very like clumsy type of table. So that is why I created those simpler tables, which we have read in the previous slides. But this is important. So I have put it here and I'll tell you the important points from this also, right? So medical therapy, now they have divided this into three: mild minimal, moderate severe, and endometrioma. So let's go through this one by one. What is the role of medical therapy in minimal or mild? We talked, there is no improvement, so no role. Surgery, we talked, minimal and mild, there is a role. It increases the chances of conception and could be considered as in a good prognosis patients. Right, so we said there are chances of natural conception after surgery. For assisted conception, no role, because it does not reduce the success of ART compared to women without endometriosis. So not much role. It has role largely when you are planning natural conception. When everything else is good, there is minimal endometriosis, then you may like to operate on it. Coming to moderate to severe, medical therapy, no role. Only role is post-operative suppression when you are preventing the recurrence, right? We talked about it. This is a repetition. Then regarding the surgery, again, may increase natural conception, but not preferred. It is not preferred. So it is only preferred when IVF is already failed, right? There is an endometrioma. You are doing IVF, but it fails. Repeatedly, it is failing. So you may like to remove the endometrioma next time before going ahead with the further cycle. The problem is that there could be reduction in the ovarian reserve after surgery. So in ART, there is low number of eggs retrieved and it reduces the live birth rate following ART. Right? Clear till now? Any confusion? Okay. Shall I go ahead? Okay. So third scenario is of endometrioma. So dynogest suppression may have a lesser impact on AMH. Now, when we talk about the medical treatments, dynogest is one new drug, but of course, it again does not have a very good role in fertility management. But by the time when the patient is like having pain or something and she's taking some treatment, so and later on she is going to go for the fertility, so it is better to give dynogest instead of the CUCs, because dynogest has seen to have less impact on the AMH. Okay, so dynogest suppression may have a lesser impact on AMH. So if you are planning to give a medication before the patient conceives, or if there is some time period in between, then you can use dynogest. That is preferred. For the surgery, cystectomy carries the risk of reducing the ovarian reserve, but it has an advantage of preventing recurrence. So routine cystectomy does not increase live birth with ART. So consider surgery if access to ovary for oocyte retrieval is not possible. So if your oocyte retrieval is not possible, then go for the surgery. What about the assisted conception? So endometriosis greater than 30 millimeter or 3 centimeter, we talked about it, have a significant negative effect on the number of oocytes. Cystectomy increases the risk of poor ovarian response to stimulation. So you have to weigh. Therefore, if you are going for the ART, don't do the surgery first. Go for the IVF. If IVF fails, then you may like to go for the surgery and then you plan ahead. So it has to be individualized. Now, what is the risk of ART in women with endometriosis? IVF does not increase endometriosis related pain, nor does it increase the risk of recurrence. You give large number of hormones, but still it does not have any effect. So that's a real good news. Ovarian stimulation has a minimal impact on endometrioma size. So while you are stimulating, it is not going to affect the size of endometrioma. Risk of pelvic infection for women with an endometrioma undergoing egg collection is thought to be less than 1%. But it is a good practice, right? It is a good practice to give antibiotics when you are doing endometriosis patient is undergoing the egg collection. But that is a good practice point, not a blanket recommendation. Then there is a concept of fertility preservation. Why there is a role of fertility preservation in endometriosis patients? Lot of young patients, they are liable to get operated because of severe pains or issues. So fertility can be issue with those. So in those cases, you may think of taking the portion or the oocytes you may like to retrieve and freeze them, right? So so you may like to do the fertility preservation in these patients, but again, this is not a routine thing to do for all the patients. This has to be discussed with the patient, right? So basically, first thing is, if at all you are planning fertility preservation, then there are certain rules. What are the rules? You should not do cystectomy prior to the oocyte retrieval. So first you do the ovarian stimulation, you take out your oocytes, and then you do the cystectomy. In most of the women with bilateral endometriomas or stage 3 or 4 disease, because these are the patients who are in which the ovarian reserve is likely to be more compromised. So in these patients, you can choose or plan to do the fertility preservation, but advice must be tailored to the woman. It should be individualized advice. Following surgery, continue medical suppression until ready to conceive. Okay. So these are the various things which you will require if you are planning the fertility preservation. It is recommended that women less than 35 years should cryopreserve at least 10 to 15 oocytes to achieve a live birth rate between 40% and 70%. So if at all you are planning to do the fertility preservation, then 10 to 15 oocytes should be retrieved. And in that case, the live birth rate would be 40 to 70%. So what is the conclusion? In young women who have mild disease and a good ovarian reserve, surgery may allow time for natural conception, or less invasive treatments such as superovulation or IUI can be tried. For older women or those with more severe disease, ART stands to be the first line and the best chance for achieving the live birth. Now in this slide, this is from the NICE guideline for the patients who are for the fertility. For them, the fertility is the priority. So let's read it so that we can compare both. So again, here is offer excision or ablation plus adhesionolysis. So again, when it is not involving bowel, bladder, or ureter. This means they are not touching the severe disease. They are not going for the deep endometriosis, only the superficial ones. You can do excision or ablation. So that is again same thing the ISHRAE or the TOG is saying. You can do cystectomy. You can do excision. So the same thing NICE also says. So no confusion. Offer laparoscopic ovarian cystectomy to women with endometriomas. Now this is what NICE used to say. Now here we differ a bit. We say that we don't have to remove endometriomas for all the patients, right? We can go ahead without that. But if we are planning natural conception in a mild or minimal disease, then we may like to do that. Discuss the benefits and the risks of laparoscopic surgery for deep endometriosis. So deep endometriosis, anyway, I told you that we are not going to deal with those patients. Fertility specialist has to deal, and these patients are not going to be operated for fertility. So the rule is same in NICE as in the TOG. No role of hormonal treatment with endometriosis who want to conceive. Same, NICE and TOG, same. So basically, there are only two main differences. One difference is IUI they have included in TOG, which was never there in any of the NICE guideline. And another main difference is there they used to say laparoscopic ovarian cystectomy for all patients, which is not now considered in present scenario. We can go ahead for the ART procedures without doing cystectomy, right? So these are the two main differences between the NICE and the TOG. Any confusions? Any questions? Because otherwise I will start with the questions. Right? So shall we start? Everybody has to answer. You can unmute and speak, answer, or you can write in the chat box, whatever way you feel comfortable. A couple attend with difficulties conceiving for the past 2 years. Woman is 32-year-old and the man is 35 years old. Semen analysis on the man is normal and the woman who is ovulating and has patent fallopian tubes has been found to have endometriosis with a 4 centimeter endometrioma on the right ovary at laparoscopy. What would be the first line management option for them? ART in the form of IUI with ovarian stimulation, ART in the form of IVF-ET, GnRH agonist for 6 months followed by laparoscopic cystectomy and ovarian stimulation with IUI, laparoscopic drainage of endometrioma, GnRH agonist, laparoscopic cystectomy following by expectant management for 6 months, ovarian cystectomy and expectant management for 6 months.
Form of IVF ET.
I couldn't get your answer, sorry.
They are in the form of IVF ET.
Okay. ART in the form of IVF-ET. Okay. So, fine. So, one answer is A. I have other answers in the chat box too. A, B, A. Okay. Okay. So, my first question is, would you like to go for the removal of endometrioma?
No.
No. Yes. Why we are not
Since
choosing?
2 years have passed.
2 years have already passed. So more or less, this is like we are managing it as unexplained till now because patient was ovulating, tubes were patent, so everything was good. So it was more of like 2 years passed. So now we have to act. So ovarian cystectomy and expectant management has no role. Now either we choose IUI and or we choose IVF-ET. As per NICE guideline, there is no role of IUI. It is directly IVF-ET. But as I told you, now they have given you everything like patient's age less than 40 years. And they have specifically given you that patient is ovulating and everything is fine. Semen analysis is normal. And the question is first line management option. So first line management can be ART in the form of IUI with ovarian stimulation. Recently added information from the TOG. So ART in form of IUI with ovarian stimulation can be first line. Most appropriate again would be ART. Right? So first line you can try with the IUI. If it does not work, then of course the most appropriate will be IVF. Right? So A is the correct answer. Okay with everyone? Any confusion?
Ma'am, ma'am, if the option was like laparoscopic cystectomy followed by ART, then that will be not the most appropriate answer.
No, because ART though there is no role of laparoscopic surgery as per now this one. Now, if once you are going for the ART, no role of surgery. Surgery only has a role if you are planning for the natural conception, because surgery has shown effect only when the natural conception pregnancy rate is more. But here already 2 years has passed, so you are not going to go for the any further natural conception. So now you have to plan the procedure. So definitely ART is the most appropriate one. But as the talk says that if everything is normal, patient less than 40 years, you can wait But till the time you are opting for the ART, you can try IUI with ovarian stimulation. And the question specifically talks about the first line management.
Ma'am, but when we give ovulation induction, because endometrioma disturbs the anatomy of the ovary, so it will also disturb ovulation.
No. That basically the concept is that if you remove the endometrioma, then it is going to damage the ovary and reduce the reserve. And in ART, you will not get enough follicles. So it is like opposite.
Okay.
Okay? Okay with everyone? Okay. So what is the effect of cystectomy for endometriomas on ART? Better response to ovarian stimulation, increased cycle cancellation, increased number of enteral follicles recruited at ovarian stimulation, increased number of good quality eggs from ovarian stimulation, and reduced cycle cancellation. Yes, it is increased cycle cancellation. Everyone agrees? I think everybody is answering B. Right? So increased cycle cancellation, this is same because number of oocytes not recruited enough. Not proper recruitment, so increased cycle cancellation. Correct. Or everyone okay? Any confusion? Right? So couple have been trying to achieve a spontaneous pregnancy for 3 years. The female partner is 37 years old and was diagnosed with endometriosis stage 3. Which of the following would be the most appropriate recommendation? Stage 3 endometriosis. So we know that for stage 3, we have to directly go for IVF. So couple should proceed to IVF as soon as possible, right? So E is the correct answer, and I think everybody is answering the same. So all good? Everyone okay? 35-year-old infertile patient is classified as having stage 1 endometriosis and was prepared for IVF treatment. After counseling regarding the treatment, she asks you some questions. Which of the following statements regarding IVF is correct? Clinical pregnancy rate for IVF is reduced in endometriosis. Miscarriage rate is higher than average in patients with stage 1 endometriosis. Ovarian stimulation could make the endometriosis condition worse. Stage of endometriosis has no impact on number of oocytes produced. And studies have shown lower fertilization rates in stage 1 endometriosis. However, implantation and clinical pregnancy rates are not affected. Yes. E. Yes, E is the correct answer. E is correct answer. Studies have shown lower fertilization rates in stage 1 endometriosis. This is because oocyte quality. Oocyte quality is poor. So E is the correct answer. Okay, fine till now. Any question, any confusion? Then we go ahead with the TOG CPD. Now it is true and false. Why we are doing true and false? Because the points are there. We don't get true false questions in exam, okay? But the points, these are the points which can come in your single best answers. So therefore it is important to revise these points. So regarding endometriosis in subfertility, around 1/3 of the subfertile women have endometriosis. Is it true or false? Okay, so true, false, both are there. True, false. What is the correct thing? 25 to 50. So 1/3 can come in that range or not? One-third is in between the range, na? 25 to 50. So this is true, right? 33%, between 25 and 50. Up to 30% of women with endometriosis have a tubal pathology. I think everybody remembers 30%. Yes, 30% is true. Endometriomas are bilateral in half of cases.
Yes.
True or false? Bit complicated, right? What is the percentage what we talked of? No, it is basically the 20% people have this deep endometriosis, and then 50% of the deep endometriosis patients have endometriomas. But bilateral is not 20%, right? It was 30%. So half of the cases is wrong. It is 30%. Okay, 50% is 50% of deep endometriosis patients have endometriomas, right? But bilateral is in 30%. Endometriosis causes an increased rate of chromosomal abnormalities within the embryo. False, yes. Everybody is answering false, so I think it's okay. The revised American Society of Reproductive Medicine scoring system is useful to predict future fertility. False. It was not good. That is why we came up to other scoring systems. So endometriosis fertility index was developed to predict pregnancy rates in women with surgically managed endometriosis. True or false? This is true. EFI was developed to predict the pregnancy rates in women with surgically managed endometriosis. EFI is able to predict pregnancy after assisted conception. Yes, again, this is true. It is true, although it was developed for the natural conception, but later on it was found that it is good in predicting ART things also. So this is also true. EFI has a high degree of inter-user variability. True or false? Oh, no. EFI is like, it has high degree of inter-user reproducibility. Means the same data can be reproduced again and again. Means it is more valid. Anything which can be reproduced again, every time you go and test, the test comes the same. So it can be reproduced. So that means that is more authentic. That is more valid. So EFI has a higher degree of inter-user. See how they fool you. In the talk, the line is EFI is a higher degree of inter-user reproducibility. And now they have changed the word reproducibility to variability. So if somebody just reads it in a quick way, you'll see higher degree of inter-user, okay, true. But it is not so, right? So this is false. EFI has a higher degree of inter-user reproducibility, not variability. So this is false. Good. Surgery for endometriosis does not increase the chance of natural conception in minimal to mild disease. False. Surgery do increase the chance. Yes, good. Does not increase the chance of natural conception in moderate to severe disease. This is true. Yes, correct. So increase the success of in vitro in fertilization in women with minimal or mild disease. False. This is only for the natural conception, right? In vitro fertilization, then there is loss of ovarian reserve. Surgery is indicated in severe endometriosis to allow access to follicles during in vitro fertilization. Now this is, yes, now this is true. Whenever you are not able to access the follicles, then you can go ahead for the surgery. Then this is recognized to result in premature ovarian insufficiency. Dr. Reshma, something is an issue. Okay, it's fine. Okay, so basically, yes, we were on 12th. It is indicated in severe endometriosis to allow access to follicles during in vitro fertilization. This is true. Surgery for endometriosis is recognized to result in premature ovarian insufficiency. Yes or no? Yes. What is the percentage? Anybody remembers?
2.4%.
2.4%. 2.4%. Yes, correct. Endometriomas are present in approximately half of the women with deep endometriosis. Now this is true. Good. 50%. When removed prior to ovarian stimulation, are likely to improve the ovarian response. Not sure. Yes, not sure. When you remove, it is actually leads to low ovarian reserve. The endometriomas managed by either by simple drainage or cystectomy have the same recurrence rate. False. Because with cystectomy, the recurrence rate is low. ART is associated with worsening endometriosis associated pain during ovarian stimulation. False. There is no effect. ART is associated with recurrence of endometriosis lesions in women who have had previous surgical excision. False. Correct. Is associated with increase in size of endometriomas by nearly 50% during stimulation. So no, it does not lead to any increase in size. Offers women with endometriosis and subfertility the best chances of achieving parenthood. Yes, correct. It is true. Good. Right. So all questions, all CPD, everything finished. Any queries? I hope now you remember this article very nicely for your exam and you will not forget this. Thank you for joining. And there are few new students here which have not yet be a part of our course. So for them, I would like to tell that we have courses with unlimited access, and it includes revision, recalls, and TOG library access. Everything is included. And of course, part 3 course is also going to start soon. So anybody here if would like to enroll, then these are the basically contact number, our website, and our email where you can contact us. Thank you.
We'll get the recording.
Yes, recording will be shared. Yes, definitely.
Thank you, ma'am. Thank you so much.
Okay, so hope you all enjoyed the session. Thank you for joining. Thank you.
Thank you, ma'am. Thank you.
Bye-bye. Bye.